Mabuhay. Good afternoon, everyone. A warm welcome to everyone, and thank you for joining us for today's important webinar, Towards Zero Harm, Learning from Medication Near Misses. I am Teddy. I will be one of your moderators for this afternoon in the webinar league. And let me lead you towards as we take a closer look on how near misses, those almost errors that never reach the patient, can become a powerful learning tool or experience that are in our mission to deliver safer and harm-free healthcare. So in healthcare, much of our focus often goes to adverse events and actual medication errors. So to clarify, a medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the hands of the healthcare provider. On the other hand, a near miss is a medication-related event that could have caused harm but was fortunately caught and corrected before it reached the patient. These close calls may not make headlines, but they hold valuable lessons about system vulnerabilities, safety gaps that might otherwise go unnoticed. So every near miss gives us a chance to reflect, adjust, and strengthen our processes, taking us one step closer to the ultimate goal of zero harm in our patient care. So today's sessions, we will explore all that qualifies as medication near miss. Why is it crucial to report them? And how learning from these incidents can lead to safer practice, stronger systems, and healthcare culture that values learning over blame. So thank you very much once again. But before we formally start our webinar, let me share with you some housekeeping rules. So our questions and comments will be shared in a Q&A section. The chat and raise hand functions are both disabled. And we, as your moderators, will highlight your questions to the appropriate speaker during panel discussion later. Some questions will be answered by text, and of course, some of them will be answered live. So there will be some polling questions later. So the polling questions, we will give you 30 seconds to respond and submit your answer. After the result is shared, you may close the poll so that you can see the slides of our speakers. The certificate of attendance will be generated and forwarded to those who will complete our post-webinar survey. And the webinar survey will be emailed tomorrow at 5 p.m. SGT time at 19th of May. Please ensure that you have correctly keyed in your full name and your email. This session is recorded and it will be uploaded in our YouTube and Facebook channel. All right, okay, so before we'll start our session and introduce our speakers, let me share with you some poll questions first. So our first poll question is that, does your institution have a reporting system for critical incident reports? So let me share our first poll. Yeah, so if you have a reporting system for critical incident events, please say yes. And of course, if there's none, please choose no. You have 20 more seconds to answer, please. Thank you very much. All right, I can see that we have completed almost all of the participants. Yeah, please answer if your institution do have a reporting system for critical incident events. All right. So based from our short survey, there are almost 91% of our attendees do have a reporting system for critical events. Oh, that is very good. All right. So how about for near misses? So I know critical incident report, like we mentioned earlier on, all the medication, we always report them. But how about near misses? Do we actually share or do we actually report near misses? Yeah. So if it's part of your reporting system, then please say yes. And of course, if it's not, then please answer no. Yeah. 20 more seconds. Yeah, thank you for participating. Please, yeah, for those who just tune in, who just join in, we are currently answering some poll questions. And this is actually our second poll question. So we're asking whether your institution do have a reporting system for near miss medication errors. All right, we'll end the poll and share the results. This is actually interesting. Almost 50, it's a 50, almost 50-50, right? 44% do not have and 56% include them in their reporting system. That's very interesting. Then our webinar will have some purpose after all. Okay, all right. So before we move on, of course, I will introduce my co-moderator for this afternoon. Okay, our co-moderator is a training officer and research officer from Section of Pediatric Anesthesia in Philippine Children's Medical Center. And she's also a research coordinator for the Department of Anesthesiology in Jose Reyes Memorial Medical Center, current Vice President of the Philippine Society for Pediatric Anesthesia, and Secretary of Pediatric Anesthesia Subspecialty Council. Mainly, of course, interests includes pediatric anesthesia, statistics, ethics, and patient safety. Colleagues, please welcome Dr. Janet Pocelero Pascual. Hi, Janet. How are you?
Hi, good afternoon. Good afternoon, Teddy. I'm okay. Based on the poll questions, we
Yeah,
can
how about?
see,
Yeah.
we can see that most of our participants have a system of reporting critical incident events. And however, we see here that only more than half of our participants have their hospitals having a reporting system for near miss medication error. So I guess we are hoping that by the end of this webinar, we develop a culture wherein everyone will be more motivated to lobby how to report near miss medication errors
Yeah,
in their hospital.
correct. All right, I leave it up to you to introduce our panelists
Right.
for this
Okay.
afternoon.
So let us introduce our speakers for today. So our first speaker is Dr. Shimaila Abbasi. She's an assistant professor at Aga Khan University, Karachi, Pakistan, and an executive committee member at the Asian Society of Pediatric Anesthesiologists. Her interests includes pediatric anesthesia, chronic pain for adults, pediatric pain, and quality improvement. Our next speaker is Dr. Tam Shuki. She is a consultant at KK Women's and Children's Hospital in Singapore, a member of the Medication Safety Committee and Medication Error Review Committee, division lead for quality improvement, and a clinical lecturer at Yung Lu Lin School of Medicine. Her interests include pediatric anesthesia, medication safety and quality improvement, and medical student education. And last but not the least, our third speaker is Dr. Rufina Teo. She's the head of the anesthesia unit at University Kebangsaan, Malaysia, associate professor and pediatric anesthesiologist of the Department of Anesthesia and Intensive Care Faculty of Medicine at UKM. Her interests include TIVA and pediatric airway surgeries. And for her research, her interests are autism spectrum disorders, biological markers, and genetic polymorphism on TIVA. So these are our three speakers. Let me now present the case that will serve as the starting point of this lecture. So we have a 10-year-old boy referred to the anesthesia service for emergency laparoscopic and appendectomy. Yeah. So at 7:45 a.m., So at 7:45 a.m., the anesthesia resident was promptly notified of the case, and he immediately reviewed the patient's history and medication records in the medical records. At this time, it was noted that no medication had been administered at the ward. At 8 a.m., the patient arrived at the operating theater reception. The transport nurse handed over the patient to the OT nurse. The transport nurse informed the OT nurse that the antibiotic had been given at 8 o'clock and would soon be documented in the system. At 8:15, sign-in was initiated by the anesthesia resident who announced that there was no medication administered to the patient. During the sign-in, the OT nurse was busy outside the operating theater, endorsing the patient since it was already the end of her shift. At 8:20 a.m., the anesthesia resident prepared the antibiotics and was about to administer them when the OT nurse suggested final check to confirm whether they had already been administered in the ward. Upon checking, it was confirmed that the antibiotic indeed had been given. As a result, the resident appropriately withheld the prepared dose and a possible duplicate antibiotic administration was averted. So let me discuss some of the important parts of the case using the Swiss cheese model. So the Swiss cheese model is a way to understand how errors happen in complex systems as in healthcare. It has become the dominant paradigm for analyzing medical errors and patient safety incidents. In this model, each layer of cheese represents a safety barrier, and the holes in the cheese represents the weaknesses or gaps in those defenses. An error occurs when the holes align, meaning all safety layers fail at the same time, allowing each error to pass through and reach the patient. A near miss happens when an error passes through some of the holes but is caught just in time by the last intact barrier. So let us apply this model to our scenario. In our scenario, the first layer of defense was the checking of the medical record where the first lapse occurred. There was delayed documentation by the ward nurse. Although the antibiotic had already been administered in the ward, this information had not been encoded. As the patient was transferred, the verbal handoff from the transport nurse to the OT nurse one was informal and undocumented, leading to another weak spot in the communication. The next layer of defense, the preoperative assessment by the anesthesia resident, failed to detect this error because the resident did not recheck the medical record upon arrival at the operating room. During the WHO surgical safety checklist sign in, there was an opportunity to clarify medications given, but was missed due to incomplete participation of the key personnel. The nurse who received the patient from the transport nurse was not present during the sign in. They were not present because at the time of the sign in, there was a change of shift among OT nurses, which resulted in a disruption in information continuity and further compounded the communication gap. Despite all these lapses lining up, each one a hole in your system, the final safety layer, which was the administration check by the OT nurse 2, was effective. Before the anesthesia resident was able to give the antibiotic, OT nurse 2 paused and questioned the medication's necessity, prompting a recheck of the patient's record and confirmation that the antibiotic had already been given. This critical action prevented a duplicate dose and turned what could have been a medication error into a near miss. So now this discussion will focus on if we encounter a near miss, do we report such a scenario and how do we go about it and what are the actions we take when there is a near miss or a medication error. So let us now have another poll question. So this is our question. In your institution's critical incident reporting process, are the individuals involved anonymized? So we have three choices. Yes, no, or we do not have a reporting process. So participants, please answer. We have 30 seconds to answer the poll question. Okay. So these are the results of our poll. So the reporting is anonymized in 57% of case of the respondents, 41% not anonymized, and only 3% do not have a reporting process. So at this point, before we start our first lecture, may I ask our panelists to comment on the results of this poll question. Dr. Rasukshi, can you give a comment on the results of this question? Being the reporting anonymized?
So, hi everyone. Thank you for inviting me to this webinar. So, I think it is interesting to see that there's a spread of answers. I think further on we will discuss about the benefits of anonymity in reporting medical errors. But generally, it is advised to keep anonymity because then it will encourage the reporting of medication errors. Um, a lot of times people are a bit worried about having punitive effects, backlash on them when they report a medication error committed by themselves. And so I think this is important, especially in near miss medication events.
Okay, thank you for that answer. How about Dr. Ratio? Can you comment on the results of the poll question?
Hi, Janet. Thank you. I think it also applied to my institution. Although my hospital system leave it to the reporting person whether they want to be identified or not. So I would say 50% will want to be identified and 50 will not be. So it's an option if you want it to be anonymized.
Okay, so thank you for that answer. So, Dr. Shemaila, while preparing for your slides, can you comment also on the results of the poll question?
Good afternoon, everyone. So, anonymity is one of the factors which I'll talk. And okay. So Janet, you need to unshare your. Okay. So it is one of the positive thing, as well as it is sometimes when you need details of something very crucial, then it becomes an issue that you don't know that which patient is that and which person we can contact. But sometimes, mostly, this anonymous reporting is one of a very powerful thing to get reports because people don't want to expose. But and the thing which we want is we want to learning from our we want to learn from our mistakes or from the incidents and from the incidents of others. So the thing happened with one person, but the message goes to everyone, and then future incidents are prevented by this. So from now I can start
Okay.
detail about the
Yeah.
reporting system.
Yes, please. You may start, Dr.
So there is nothing to disclose except that I'm member of multiple places at PSA, ISP, and ASPA, and my interest is one of the interests is quality improvement things. So when we all know that internationally there are different reporting systems available, like National Medication Error Reporting Process, and MedWatch, the FDA's Medical Product Safety Reporting Program, the National Coordinating Council for Medication Error Reporting and Prevention. So they are very fantastic programs. WHO also has the Patient Safety Incident Reporting and Learning Manual, which is very elaborative, and we can learn from this manual if someone want to adapt this system. It is a very important issue, the medication errors and the cost related to it. So the data suggests that the US FDA receives over 1 million reports annually, and their annual cost on this medication error has been estimated as 42 billion US dollar. So it's a huge cost. So now we will come to what we are doing at our setup in Pakistan. This is my university. where I work. And we have the oldest system is our critical incident reporting system, and our pharmacy also had a ADR cards, which if any error occurred, which is purely due to medication, not by a human, then we can report on the hard copy, but later they switched on the online system. At university level, we have an adverse event management system, for which I'll talk in detail at in the later slides. So first, I'll talk about our critical incident reporting system at AKU in Pakistan. So it is approx now, it is almost 30 years when it was started on a very simple form, and by one of my mentors, Dr. Fawzia Anis Khan. She started that system alone as like one person, and then we gradually we joined the group, and we have in the initial phases it's difficult to tell people that yes, this is an incident and we need to report, this is a near miss, but we have to report small things. So training is one of the thing in initial phase, and the initial challenges were many, but two of the challenges which are still persist, that people take it as like this can happen. Okay, this happens. I detect it. Okay, fine. It's okay. So they don't want to report everything. So few people sometimes have fixed ideas, and those fixed ideas is very difficult to remove. And the second challenge we always face is the change of like trainees every year. There's a lot goes out and a lot comes in, so we have to again train all those the newcomers. So then what we did, we thought that we can improve the system by the ownership. So we increase the group members and the representation from all areas. Like the hospital is expanded, and we expand our reporting system as well. Like we started in the obstetric anesthesia unit as well, in the daycare unit as well, where daycare surgeries are performed, and out of OR, there are many anesthesia things going on out of OR, like NORA. So we tried to streamline the workflows, and data integration is one of the phases from which we have passed, and now our data is in the SPSS, and we can always go back and take out the things which we want. So now we are almost at the maturity phase. In the regular meetings are there, small group discussions, presentation in larger group, and the continuous improvement we are striving always. So, and the long-term benefits out of it is prevention of morbidity and mortality as you intervene in between, and when people know that this happened, the thing which is picked earlier can prevent a morbidity as well. And then the sharing of knowledge till its action, development of protocol and guidelines through it. So this is the flow roadmap of how they fill. They drop it in a box. They collect. We collect and assign the code on all forms, which is done by the coordinator on monthly basis, and then data entry and cross-checking by one of our secretarial staff on a monthly basis, and then discussion in critical incident, and then if suggested by the group, reports which require immediate information or action. So we need to email or contact immediately to the stakeholders. And then with some actions, and for more suggestion, we present it at larger group in the department, the whole department. And where our whole faculties there, our residents, trainees are there, and sometimes we also invite our technicians, or we can go to our anesthesia technician group, because they are side by side always in our daily anesthesia practice. So we present quarterly to the whole department. And then if someone is on leave, they miss the meeting. So the last step is lesson to learn email to the whole department on quarterly basis. So how we use this data or knowledge, it is disseminated, it is used in faculty lectures, in meetings at departmental level, in meetings at national and international level, and through publications. So we have a bit of publications of this critical incident reporting. And this is our form, which is like every 5 year, after every 5 years, we try to revise it, improve it, and now this is it is in this shape as it is. Soon it will go on for online. You can see the check boxes. So these are different patient age, surgical procedure, location, surgical specialty, time of occurrence, ASS status, type of anesthesia, when did the incident occur, system involvement. But you can see there's no date on it. There is no name on it, neither the name of the reporter nor the name of the patient or any MR number. So what happened, different categories. So one of the categories, medication error, for which we are talking today. So there are different things in this medication, even like allergy, ampoule or syringe swab, dilution error, ineffective drug, incorrect route of administration, interaction, labeling error, overdosage, omission, side effect, underdosage, wrong syringe, wrong concentration, wrong drug administered, and wrong drug prepared, or if anything else, they can mark on other and they can write the detail. And the next part of this form is, why did the incident occur? So it could be the patient factor, system at fault, equipment failure, technique-related error, medication error, or personal or human factors, which can be further divided into, because human factors are the one which are always on the higher side, and there are different reasons why it happened. So they can be we can correct these things by different actions. And the last part is the outcome, where we divide the outcome into near miss and the active failure. And the active failure is the one which we divide into minor, intermediate, and severe morbidity and mortality. And we have definitions in the last part of the form, which is what is minor, what is intermediate, and what is major morbidity. And their contextual details can be filled in as actual incident, why it happened, and what are the suggestions by the reporting person. And as we all know, there are different phases of drug handling. So you can see a green, a very rough line. Above the green line are all the phases: the anesthesia plan, physician order entry, dispensing, preparation, labeling, to save the drug in the next patient bin. Till this point, it is, if anything goes wrong, it is a near miss. Even if you take the syringe in your hand, still that is a near miss. But once it reached to the patient, it became an active failure. So one of the example, an interesting example, which is like we can say that sometimes the system are at fault, but sometimes the system save you. So one of the resident who joined the rotation of cardiothoracic anesthesia, he has to do the physician order entry. So he was entering the medications, and rather than sodium nitroprusside, he or she, I don't know, entered sodium tetradecyl sulfate, which is an sclerosing agent used for these varicose veins by the vascular surgeons. And the medication was dispensed to the OR, and he prepared and he loaded on the infusion pump. And as a routine, the cardiac fellow came in and he started checking all the things, and he's quickly found that there is an unusual ampule on the medication trolley, and he asked, and then it was turned out that it is a wrong drug, so it was removed. So it would be a catastrophic event in a cardiac patient or in any patient, but fortunately it was a near miss, but just because a system of double checking. So I'll just quickly go through the critical incident process. What are the how the process flows? That the reporter reports and the data come to us, discussion in a small group, dissemination in larger group, and then the lesson to learn email, by which the reporter also get the input that what happens to the report, because it's very important that if someone reports, and he must get the answer, and he must get the news that yes, this is not disseminated to everyone, and what are the suggestion by the other people. So first of all, this is the beauty of this process is this is anonymous, it is a voluntary reporting, it is for the awareness and education of everyone. It is non-punitive, no Hawthorne effect. It takes only 5 minutes to fill this form, and there are certain topics comes out of it for discussion in our meetings, like in journal clubs and in our evidence-based meetings. And sometimes there are something for the research. And there are certain limitations that the numbers are not actual numbers of report. So whatever is happening, it's one of the things that this is the biopsy of the system. And sometime another limitation is when someone fills but doesn't like to write the whole text. So we can't take a message from the reporting person that what you want to say. So sometimes there's a lack of text, otherwise it's always the boxes are full. So if I'll compare it to the hospital-wide adverse event management system, and though it's a very beautiful system, it has a database, everything. It's also a voluntary system, but it is what we see is it is mostly used for complaint of someone who committed mistake, and sometimes for the improvement of the system as well. There are sometimes punitive actions. It takes 20 to 30 minutes to fill it, and it is a generic form for every adverse event. It is not only for the medication, it is not relevant to the anesthesia practice. So if we want to report something, we found it difficult. So the reporter again gives a report data with patient MR number. So there is nothing confidential and nothing anonymous. And the committee starts investigation from the teams involved in the email chains, comprehensive root cause analysis, is performed, and then to maintain the confidentiality, it is not open for everyone. So only people, the one who report and the people involved in investigation, and the quality improvement representatives knows it. And then the data goes in the computers and the files, and sometimes some policy comes out of it. But at a large, there's no rationale why this policy came. So what are the future direction? So by the end of this 2025, an online system will be introduced on the REDCap. For 2026, it will be hybrid, and from 2027, it is pure online. So I mentioned one point that when a new lot comes in, there are more incidents. We have seen that there is a rise in the critical incident reports, and people, though there are classes, there are orientation programs, but still there is some lack to know the standards, what are the basic standards of the department. So when they don't follow the standard, it comes to the like deviation from the standards, and one of the human factor of the cause of the incident. So we decided to design a medication manual. So for any trainee or any faculty who join the department can go through that medication manual, and we can practice on a standard format. So there would be no deviation from the standards, and we can improve. So while I was preparing this talk, this question come to my mind: do we have any reporting system in Asia? So later we can talk on it. And here I'll stop. It doesn't matter how slowly you go, as long as you do not stop, you improve. Thank you.
Thank you very much, Dr. Shumaila, for that very comprehensive presentation and very inspiring. I hope those who are attending our session who do not have any reporting system yet may have some inspiration from what you have shared, and maybe they can start their own reporting system. Yeah, and as you have mentioned earlier on, you should start somewhere. Yeah. All right, moving on to our next topic for our discussion, right? So Dr. Shumaila discuss about the reporting system. Then the next question is, what do we do about it, right? We have all the data. So we have a poll question here asking if there is a designated committee in your institution, right, that reviews your medication error reports. Yeah, because we have the reporting system, we have all the numbers, but the next question is, in your institution, do you have a committee or even in your department looking after these reports to be analyzed? Yeah. So you have maybe another 15 seconds to answer. So please, viewers, we need your share your experience, your institution's policies and workflow so that we can all discuss. Yeah. In fact, Dr. Shumaila opened up a very interesting question, whether in Asia do we have a reporting system as a region. So we can discuss that during the Q&A. And yes, for our viewers, we encourage everyone to key in your questions, comments, suggestions in our Q&A box, and we will discuss it later during the panel discussion. All right, we have the results. 77% actually have a committee, but however, 23% do not have a committee in their institution that reviews their medication report. Dr. Suchi, do you mind giving your comment with this result?
Hi, Eddie.
Hey, hi.
Okay, so it's really good to see that most of us have a medication error committee. Although I think more important than the committee itself is actually how we analyze and deal with the reports. Okay, so I think that is also something that will bring me to what I will discuss in my presentation, and also I will talk a bit about the merits and demerits of having a medication error committee. Okay, so I think with that, let
Please
me
carry
just
on.
start and share my slide. Okay, so thank you for the previous speakers, Dr. Janet and Dr. Shamaila. And today I'll just be talking about analyzing medication errors. Okay, and for this segment of today's talk, we will be discussing on how to analyze medication errors. Okay, so in particular, an example of a classification system based on causation of error and an outcome of an error. Okay, so we will then go through an analysis of the case scenario presented earlier by Dr. Janet, using a classification system to aid in the analysis of the medication error. And finally, as what we mentioned earlier, who should be involved in medication error analysis? Okay. Right. So firstly, why do we even perform error analysis? The goals of error analysis is to look for possible causes of the error, okay, and then seek solutions for them. So this can be divided into causes as a result of deficiencies associated with a specific event that resulted in the error, and or deficiencies in the design of a system. Okay, and I acknowledge that there are many different classification systems for medication errors. Okay, this is just one particular classification system, which is used in my institution in Singapore. So this is the Human Factors Analysis and Classification System, and we call it HFACS for short. Okay, so the HFACS classification system was actually developed by behavioral scientists in the US Navy, and it is used in multiple industries. So for those who are not familiar with this classification system, it has four main barriers that can result in an error. From the bottom, you can see unsafe acts, preconditions, unsafe supervision, and organizational influences. So the top barriers have the ability to affect the bottom tiers. For example, organizational influences can result in deficiencies in unsafe supervision. And in each classification level, defect in safety barrier can cause a hole in the Swiss cheese, as you can see in this image, as also Dr. Janet mentioned earlier. When they are aligned, they can cause an error. And identifying these holes at each tier can result in a step towards zero harm. So within the HFACS model, there are four causal categories that result in a failure. These are as mentioned earlier, and these are in the red squares. Okay. So technically, at least one failure will occur at each level, which can lead to a medication error. As there are many factors and descriptions of each factor, you are welcome to read further at the HFACS website. But briefly, so the lower tier is the unsafe acts. So this is actually at the individual level. So for example, a routine violation is when the individual disregards the protocols intentionally. Okay. Precondition to unsafe acts is the next tier, and whereby the factors that could precondition or influence an individual to fail at a task. So for example, this could be situational factors such as the IT system, which has poor visual display, for example, resulting in an error. Or even personnel factors such as there being a poor communication or handover between healthcare staff. The next tier deals with supervisory factors, so such as the staff having inadequate supervision or supervisors failing to correct a known deficiency, resulting in failure. And now the highest tier is organizational influences. So this could be due to poor resource allocation, be it manpower or even budget. And the organizational culture could also be one that does not promote a culture of safety. So if you are especially punitive towards those who make errors. Okay, so we will use the earlier case scenario to illustrate the use of classification system for analyzing medication errors. Okay, so in case it was a bit too brief, or if anyone had joined us late, in brief, this is the case scenario we presented earlier. A 10-year-old boy is going for a laparoscopic appendectomy. Anesthesia resident clerked the case and noted there was no medication given in the ward. Subsequently to the resident checking, the antibiotics was given. And when the patient reached the OT reception, no medication check was done. The transport nurse handed over to the OT nurse that antibiotics were given. However, at the sign-in, the OT nurse was not present as she was busy. So the anesthesia resident at sign-in declared that there's no antibiotics given prior. And the second nurse caught the error just before the anesthesia resident administered antibiotics to the patient. Therefore, this was a near-miss event and the antibiotics was not given to the patient. Okay, so analyzing our scenario, it is easy to pin the blame on a routine violation, right, by the resident and the nurse. So after all, the resident failed to check the intraoperative medicine given upon the patient's arrival. And also the operating nurse was not present at the sign-in of the patient to point out the error. However, diving deeper and using a classification system such as the HFACS, there could be precondition for unsafe acts. Okay, so there was poor communication and handover of medication from the ward nurse to the anesthetist. And furthermore, this is only, like, for example, specific to an IT system. Could there be design issues in the workplace, such as there's no available computers for the anesthetist to check medication at the operating theatre reception? In the supervisory tier, there are also obvious staff shortages, which resulted in the operating theatre nurse being busy with another task at sign-in, and therefore she was not present at sign-in. Was there a failure to address staff shortage in the operating theatre? Lastly, organizational influence. So could there be inadequate resource management, such as inadequate nursing manpower in operating theatre? Was there inadequate computers present in the operating theatre? This classification system encourages us to investigate for a higher tier cause by asking why. Okay, so not just looking at the individual level, but going tiers higher. For example, in the first tier, there was a routine violation by the resident who did not check medication given at the operating theatre reception. Is it due to the resident being new and he was not being orientated on when to check the medication given and how? That would fall under unsafe supervision and would result in a push for better orientation for new residents instead of pinning the blame on the one resident who made this error. So now, why is it important to analyze near-miss scenarios? I think in this scenario, an error was not made and the patient did not come to harm because the antibiotic was not given. Why must we report and analyze this scenario? As can be seen in the Swiss cheese model, a near-miss event does not equate to there being no safety barrier breaches. In fact, the fact that there was a near-miss event usually means that there are multiple levels of breaches in safety barriers already present. In this case, it was only due to the safety culture of speaking up, which comes under organizational influences, that eventually prevented the error. So if you remember, the operating nurse 2 actually spoke up and said, hey, I think there's an antibiotic already given. Would you please check again? And that prevented the actual error from occurring. Okay, so now just touching on one particular classification system for medication errors that is based on the outcome of the error. So just now we're talking about causation, causes of the error. This is the outcome. So this is a 9-point classification by the National Coordinating Council for Medication Error, Reporting and Prevention. So it is the NCCMERP for short. And it classifies the error based on severity of the outcome. So a near-miss error is actually category A. Category B to D include errors that reach the patient but result in no harm to the patient. Category E to G has temporary or permanent harm to the patient. And H and I are near death or death resulting from the error. So in my institution, medication errors are also classified by this classification system as any category that is E and to I, which basically result in harm to the patient, are considered serious reportable events, or SREs for short. Okay, so SREs are require investigation at the national level instead of just an institutional level. Okay, so this brings us to the question of who should analyze medication errors. So this likely varies based on different countries and institutions, but this is a model that is practiced in Singapore where I practice. So at the first level, the error is analyzed by the team involved in the error. So a root cause analysis is performed. And the advantage of this level of analysis is that the event-specific factors are easily picked out. So now just touching on what we mentioned earlier about anonymity. So at this level of the analysis, as you can tell, because it is a discussion between people involved in the event, this is usually not anonymous. Okay. So for example, if the doctor administering the medication was distracted by many tasks that day, this will be brought up in this level of analysis. So it's an event-specific factor. Okay, next at the department level, this report is anonymously analyzed at the department meeting. And this accords a more macro view of the error where it is drawn upon collective experience of anesthetists that may be that function in the same setting. Okay, it also allows for third-party observations that may be blinded to the team that kind of committed the error in the first place. Subsequently, the case is again discussed at the Hospital Medication Safety Committee. So this error is distilled and classified based on the HFAX classification in my institution. And the benefit of this is that the committee is empowered to effect larger organizational change with access to hospital management and leadership. At this committee, we also observe larger hospital-wide trends. For example, the Medication Error Committee recently conducted a quality improvement project to reduce medication duplication errors as a result of communication or handover lapses in the operating theatre. Okay, there was also a separate analysis of errors in oncology wards, where there were a cluster of medication errors that were picked up in these wards. Lastly, as mentioned earlier, all serious reportable events are analyzed at the national level by the SRE Quality Assurance Committee. And they review the cases and perform a root cause analysis if required and roll out national level policies where applicable. So who sits on the medication safety committee in my institution? And I note that there are 77% of us who have a safety committee. So in Singapore, this is the makeup of our committee. The chairperson is a clinician. And the group comprises quality and safety leads. So these are actually non-clinicians, but they're highly involved in all quality and safety projects. The pharmacy practice manager is also present. Physicians as well as nursing managers. And this is a representative, there is a representative nursing manager from each discipline or ward, which is part of this work group. Okay, so thank you for your kind attention. This is the end of my on analysis of medication errors. And I'll now hand the time to the next speaker.
Thank you very much, Dr. Sushi, for a very in-depth discussion of analyzing medication error reports. So before we go to our next speaker, let us answer our fifth poll question. So for our question, have you participated in a quality improvement initiative based on findings from a critical incident or a near-miss event? So for the participants, we give you 30 seconds to answer the poll question. Okay, so these are the results of our poll question. So 51% of our participants have participated in a quality improvement initiative, while only 41% have not participated. So this is a good number. So I know that Dr. Sushi is a member of the Medication Safety Committee and Medication Error Review Committee. So she definitely has experience in attending these initiatives. How about Dr. Shamaila? Do you have any have you participated in any quality improvement initiative?
Yes, Janet. There are different type of quality improvement initiatives in our hospital as well. The basic things are like audits, medication audits, with which we can have the particular results, and then we can make some guidelines out of it.
Okay, thank you very much, Dr. Cho. While you're setting up your slide, can we get a comment regarding the poll results?
Hi, thank you again, Janet. Yeah, so I think all of us has been involved either directly or indirectly in any of the initiatives. So if you are a young junior doctor, you probably have been involved in as a part of the day-to-day guidelines policy kind of involvement, whereas those senior ones probably will be involved much at the policy making tiers. So yeah, so it's a fair poll, I would say. Let me just share my screen to...
Maybe while Rufina is sharing her screen, let me invite our viewers to please key in your questions for our speakers in the Q&A box, and then we will answer them later. Thank you.
Okay.
Okay, you see my
Okay.
screen?
Yes, we can see your screen.
Thank you. So the last part of this talk is really how do we turn these reports into actions, right? From near miss to safe practice. Yeah, so in my hospital, all reportable incidents or near miss are reported directly to the Quality and Risk Management Unit. And this is then further classified to the nature of it, whether it has some financial implication, whether it involves any compliance, reputational, or technological effect out of it. And it is then subdivided into whether the impact is low, moderate, and high. And based on that, it will be brought down to whether either this need to be discussed at departmental level or at hospital level. So really my talk is at the second last of the tier in this WHO management ladder for the incident report. And basically the best practices for sustaining a safe practice and near miss program. Sorry, just go back. Are really into these 5 points. This is generally very available where you the leaders need to have some foster open communication, where leadership involvement is very important, using user-friendly reporting tools, implementing corrective actions, and so on. But in reality, very few health systems can come near to ideal level of performance in capturing and learning from incidents of avoidable harm. And facilities around the world have shown that analysis of incidents can lead to safety improvement only in the high-income countries as compared to low and middle-income countries. And there are many challenges in trying to deliver benefits from this incident reporting. Some of the points are really in difficulty establishing safety culture, like what previous speakers have mentioned, based on a blame-free reporting, where learning is more powerful than judgment. Maybe this is due to a poorly designed system and processes to start off with. The other thing is the core data of incident reporting systems are often too often is a matter of local opinion. A detailed multidisciplinary investigations are less commonly done. This can be due to mainly logistic and also resources issue. And in reality, the process of achieving sustainable reduction in risk and improvement seldom works very well. So, but we still need to do our part, and at the ground level, we need to foster an open communication, create a just culture to balance the accountability with learning. So incident reporting generally, like what Suu Kyi has mentioned before, it can be voluntary or mandatory reporting. So involuntary, it has been shown that it promotes culture of safety and it's beneficial for medical learning. Whereas for mandatory, it is proven to be effective in reporting participation, have an organization accountability, and improve patient safety and prevention program. So good and bad in both systems. While having to foster open communication, implement user-friendly reporting tools, what I want to emphasize in my talk is really how we can implement corrective actions after the reporting has been done. So once the reporting has been done, the system-based interventions are implemented as general. For example, the standardization of medication process. So I'm sure a lot of us will have some local protocols, checklists have in place. Automation has replaced the manual one with barcode scanning. CPOE, a computerized physician order, like what Dr. Shumaila has mentioned, and also a change in environmental design, mainly with the improved labeling. So the CPOE has become a game changer, mainly to reduce errors related to poor handwriting or prescriptions. I cannot imagine how many years ago where our pharmacy was trying to dispense drug based on the prescription done by our doctors. For example, the one here that we can see at the bottom left, this is just merely going to be a disaster. So CPOE actually enable real-time clinician decision report and also to counter-check whenever you click on a specific drug that, for example, the one that has been shown in the upper left. So it actually improves workflow efficiency and documentation, right? So by the way, this prescription really says it's erythromycin 250 milligram once QID. So yeah, so for the next few slides, I'm going to share what my hospital has done in terms of medication safety. So the first one will be label specifications. My hospital does the label based on the standard by the ASTM and ISO, where the drug name are all generic as in the Ministry of Health drug formulary. And we use Tallman lettering for Lassa drugs in Arial font, size 10 in bold. So for example, rocuronium, we use this Tallman lettering with the dose concentration. And moving forward, so I work mainly in the children hospital. So I've moved from the adult hospital and moving to a new hospital. We have made throughout the years, made some environment and also workflow redesigning to improve our patient safety, mainly in the identification of the patient once they reach the operation theater. So in this new hospital where the entrance to the operation theater is mainly governed by one entrance, and we used to have only 2 staff to man the receiving end of the patient and also to manage all the other non-medical staff who comes in. For example, our engineers will come and do their morning round checks, and also the infectious unit team will do their morning rounds check. So all these are manned by 2 staff at the reception only, until one day we have one, because there's so many inflow and outflow of people around together with the patient. So one of our staff nurse actually misidentified a second twin who happened to come for the same procedure as the first twin. So now we have redesigned the workflow where we have dedicated staff to man just for the incoming patient and another dedicated staff just to man the non-patient that comes into the reception for reporting and all that. This is more on the identification of patient rather than medications error kind of thingy. So in the adult hospital where I used to work with, the sign in or time out kind of procedure is done when the patient is pushed into the theater and where all the safety checks are done. But with children and patient in the children's hospital, we find it very difficult because once the patient and parent or guardian push into the theater, a lot of things happens, and the child will be anxious, mom and dad will be very anxious, and all the identification check is very difficult to do and very noisy. So we have done away with that. So we do our check-in, sign-in identification of patient at the reception, where these patients are placed and parked before they are pushed to the theater. So in the theater itself, only the procedures, confirmation, and the site of surgery, and mainly the allergy to any medication and also any other concerns are checked. The rest are done at the reception area itself. And being a teaching institution, we always receive junior doctors and outside doctors to come for attachment or rotation. And this is something new. And we had an incident where there were too many anesthetic doctors who were sort of like in charge of the list on that day. So what happened was one junior doctor was preparing the drugs and pass it on to the senior doctors. And so it's a series of things that has gone unchecked and has caused a medication error in a person. So what we have done now is we don't limit, we still need to receive all these attachment doctors coming into theaters. So we have assigned specifically their tasks for that specific patient. That means only one anesthetist doctor will be in charge of that patient solely, and the second and third doctor, if available, they will be doing the non-essential, for example, documentation, writing up the patient's sheet and all that. So only one doctor who is solely in charge when dealing with the patient itself. This is just to show that our medication labeling, we are trying to, we are doing a trial run of an audit currently. Is that we found that doctors who come in from other departments, for example, the emergency department, they are not really familiar with the drug concentration that we are used to. For example, ropivacaine, we usually will say it in a concentration percentage, for example, 0.2%, 0.75%. So we found that with many other doctors coming in from other department and background, it is very difficult, and they've got problem with adjusting the norms of the language of the drug, and therefore we have done away with the percentage. So we go with the concentration proper itself. So whether it's 2 milligram per mil or 7.5 milligram per mil, rather than the concentration percentage. And I'm not sure with your institution, but in my institution, we used to have surgical colleague who come and share our GA trolley to prepare the antibiotics and drugs. This is very peculiar to all the government hospital, where we have different tiers of doctors coming in doing different tasks, but sharing the same workspace. So now with the new children's hospital, to prevent medication error, we have actually prepared a small corner for our surgical colleague to prepare their drugs, so that they don't get confused with our drug diluent and also other medication, which has come to a more problem recently because of all these generic drugs. They come in many sizes and forms, and they keep changing all the time. So we have no control of that, and we decided that instead we will separate the work area for our surgical colleague. And our dear pharmacy also have done a great job in helping us to minimize the medication error for especially high-risk drugs. So like here we have the heparin concentration. So in my hospital, we have two concentration, 5,000 unit per mil and the 1,000 unit per mil. So the pharmacist colleague have rightly help us to separate them correctly. So the 5,000 unit, which is more rarely used, is placed on top of the rack, where you need to really reach out in order to get it, as compared to the 1,000 unit per mil, where it's more eye level. So placing a drug with the same name and different concentration is not recommended by our pharmacists next to each other. Now, like Dr. Shumaila have mentioned, it is also very important to establish a feedback loop. For example, it's very useful for the reporter to have feedback from the incident report that has been done. And also what's more important is the trend analysis. So a near miss incident or an event that has occurred in one department may have also occurred in another department, for example, in NICU setting. So it is also important at the hospital level to have a dashboards of event that occur in the hospital itself as a bigger overview to have this risk management done correctly. And of course, staff education and feedback. We normally share the near misses stories during huddles or CME session, and implemented targeted training, for example, a safe prescribing practices, which our pharmacist colleague have actively be involved in our hospital. So in conclusion, what I'd like to say is near misses are really early warning sign, which all of us should take an important note, and we should be part of the team rather than just at the management area. And we should emphasize a hospital-wide commitment to learning and improvement. We should also build a community that thrive that community that can thrive and feel safe, because day-to-day work stops feeling fun and safe when the leaders are hardwired on system and efficiencies and processes. So with that, I would urge all leaders to stop, listen, and reach out to all their staff from the lower ground up to the higher tiers. That is my last slide. Thank you.
Thank you very much, Rufina. And of course, thank you very much for all our panel and speakers for this afternoon. We will now move on to our Q&A. And I think there's one question in our Q&A box. Maybe Dr. Shamila managed to answer it, but I will ask other speakers as well. Do the panels think that compulsory counseling session by a counselor after the root cause analysis meeting with the persons involved be beneficial as part of the step during the analysis? Maybe I'll start with Suchi. What do you think?
Yes, I think this is a very good point, and I must admit, I think in my institution we don't have that kind of workflow currently. I think it's definitely beneficial, but it possibly depending on the outcome of the event. So I think if there's patient harm involved, there should be some amount of counseling. With that said, I think in a recent medication error involving a resident, I could see that she was a bit kind of traumatized by it. Especially during the RCA. So I think we had a bit of a chat about it, but there was no formal counseling. I think that's definitely something that we should look at actually.
How about Rufina?
Yeah, I think it's really a good idea, and all this mental support and unofficial support is really important, not just for the victim itself, but for the second victim, really. Yeah.
Yeah, Dr. Shamila?
Yeah, I think it's very important as we are not stopping there. We are dealing day in and day out with our patients and with the colleagues as well. So by doing the counseling, the person has more confidence in his or her work, and it should be a non-punitive type of counseling as well, and it should be they say as a feedback and a sandwich technique, and we must support if something has happened very wrong, especially for the juniors who just joined and something happened, they got too much afraid of it. Sometimes they take it on their nerves too much that they can even do more harm in future. So we have to give them confidence as well that okay, this thing happened, now what would be the way forward.
Yeah.
And the report, and then we also must ensure them that this reporting is a positive act, rather than hiding.
More for the learning purposes,
Yeah.
and change rather than blame. Yeah, so I think we've seen the transition. All of our presenters gave us an idea on how to start a reporting system, how to analyze, and Rufina shared some of the quality improvement initiatives from her institution based from this report. Then during our first poll questions, right? First two poll questions, we have a number of attendees right now who doesn't even have a reporting system. If let's say, right, if I don't have a reporting system in my institution, how can I start? One, what will be your advice to these attendees who until now still don't have a reporting system in their department? Not necessarily the whole hospital, at least within their anesthesia department. Maybe I'll start with Rufina. What do you think will be your suggestion or advice to these attendees who doesn't have any reporting system yet?
Yeah, I think we all started from none, and this is all the system that has been brought down to us. For example, for me, where I used to practice in the adult and where the adult and children patient are in the same hospital, when I moved to the new children hospital, there isn't really a proper reporting system for us. So we have no choice, but we start small. So we start at departmental level and slowly grow into interdepartmental level, and we involve other unit as we go along. So it really to start off, it starts small, I would say. Yeah.
Yeah, I think Rufina mentioned about the proper reporting system. Maybe Dr. Shamaila, I think you're the one who shared with us your reporting system. Would you mind giving us some tips and ideas on how we can actually start a reporting system? And we have seen from your presentation also that you have a moving forward plan to make it an automated rather than paper and documentation. Please can share with us. Let's say if I'm the one I want to start a proper reporting system, how should I start a small group? And then what are the things that I need to prepare?
So I think just for someone who just want to start, first very important thing is you can have your own the form according to your setup, or a generic form from us as well, or like present in the literature as well. So you have to prepare the data collecting form, and then first of all, you have to present it in your department. If you are starting at the departmental level, first of all, present it in the department. And one nice tip is take someone who is the like higher authorities in your group. So the things would be easier, and try to do it on a regular pace. Like your presentations should be on a regular pace. The after the data collection, there must be some dedicated person who collect the data, who enter the data, and make a report and regular presentation of the reports. And then whenever you present some report, the day on which we present in our department, people go back and they found the incidents very easily. Like there is just like a revision that yes, this is a system is there, and like we can easily pick the incidents. So regular presentation is one of the key features to start and sustain.
Yeah.
One thing which is a very true thing, that this is something which does not give you anything like and it don't help you to like promote yourself, but this is the thing which promotes patient safety. It promotes your safety culture. It promotes inner satisfaction that you did something on a larger scale can prevent 100 of incidents.
Yeah, learning
So
from
this is
Yeah.
Oh,
Yeah. Thank you, Shamaila, for that sharing about the
is
benefits of having a reporting
is
system.
chosen and published that would more rewarding.
Yeah. Thank you very much, Dr. Shamaila, for sharing with us that how to start your reporting system. We've seen earlier on during Suchi's presentation, she gave us a very nice analytical steps on how to analyze and how to categorize reports as well. Suchi, do you mind if, let's say, you mentioned earlier on about the 9 steps, right? Maybe if you still have the slide with you, do you mind sharing back that slide so that those who just log in late can go back and see that slide again. So my question mainly, if let's say, right, if I'm reporting a near miss, right, near miss report, then where will it go? Will it actually, how much intense in terms of analysis you will do for a near miss report based on this classification of medication error outcome?
So, Teddy, you're referring to this particular slide, right? Okay. So actually, the near miss would be under category A, which is also a capacity to cause error, but no error occurs. Actually, the near misses are reported and analyzed in exactly the same way as the other categories of errors. So, in that sense, because as we mentioned earlier, near misses are not something that to be taken lightly, because it just means that one particular safety barrier has prevented it from becoming an actual error, a critical incident. So actually, we do analyze it in the same way. It even goes to the medication safety committee. And of course, a lot of near miss events have actually resulted in practice change or even workflow changes. So it doesn't matter actually if it's a near miss or it's actual adverse events.
Yeah. Yeah, thank you very much for highlighting this, Suchi. That's the one actually I wish to highlight, that even if it's a near miss, it actually requires or warrants the same amount or same intensity of review as compared to other actual adverse events or medication errors as well. I think one of the questions I want to ask our panelists is whether or not, based on your experience and practice, can you share with us one near miss experience apart from what we have shared, the case that we have shared just now? What did one experience of near miss, and can you share with us and what you have done for this near miss experience? Maybe I will start. Maybe Rufina, I ask you whether have you encountered recently a near miss wherein you managed to change your system and able to at least lessen the incidence of this near miss?
Yeah, interestingly, I just recently, it was just by chance, not really a near miss in conscious level. So I was running this a circumcision list. So happened so usually circumcision in pediatric are done by our general surgery pediatric surgeon, but little did I know that our plastic colleague has also started doing it for our pediatric population. So when they came and obviously circumcision is done by just the trainee fellow level. So they came in and they have just ordered the cocktail for the local anesthetic to be given. And in my institution, the surgeon give the local anesthetic for the circumcision. So I was just in my casual way just to ask how much and what is it that you're giving, out of curiosity. And to my dismay, that the plastic surgeons they've got different regime. So the drug calculation are totally just blanket cocktail for the smaller adult kind of thingy. So it really, so I wouldn't say it's a near miss, but sometimes out of curiosity or something that is out of norm, it is also good to just double check just in case, and a lot of times running a light list may render us to be more less careful with
Relax.
our normal. Yes. Yeah. So yeah, so that's just one
Thank you
bit.
very much, Ravina, for sharing that. I think earlier on, Dr. Shamaila shared about Asia, right, in general, do we, because I know internationally, right, Dr. Shamaila shared about in Western side, they have their own regional reporting system and they have their own branch wherein they can share how they're reporting. I think Dr. Rebecca asked and follow just to relate to that question, how can ASPA help in terms of setting up a generic forms for reporting like Dr. Shamaila has shared, and data collection and organizing the data? I think this is in response to what Dr. Shamaila asked earlier on at the end of her presentation. Dr. Shamaila, would you like to comment and answer Dr. Rebecca's question?
Yes, of course. For anesthesia, not only for the medications, but overall for anesthesia, the forms are more or less same. So a generic form for reporting thing can be we can think of it, we can start on it, and right now what I'm doing for my department is that the same form we are switching it to the online form, so we can have some link on which everyone can only if we say that if there is no confidentiality or any other issues there, just for the sake of learning and education, we can put those incidents for educational and awareness purpose.
Yeah. I think what we can actually do is to help those who are actually do not have a reporting system yet. We can have a depository of all of those reports format, because there's no one reporting form that fits everybody. So maybe you can share yours, and then Shuchi can share what Singapore is using, and the same with Rafina. And then all of this reporting system forms that each institution use, for those who have, we can compile it in one resource, and then everybody can refer to that, and they can adapt and combine, and then based from that they can start their own reporting system. And I think moving forward, the patient safety initiative as well, there's SIG. We can actually compose and collect this data. Yes, Dr. Shamaila, you raise your hand.
Yeah. So in addition to the same thing, I just have a comment that critical incident reporting doesn't stop at just reporting. So if we start it, in the first phase, it could be for the educational purpose, but when you want to close that report, there must be then some people, a group should be there, a committee should be there to handle those reports, that where to close it.
Yes, correct. That's my next question now to Suchi. So Suchi, if let's say, right, I don't have a reporting system yet, and I want to analyze, and I want to be as expert as you are, any recommendations or suggestions where we can actually learn the things that you just shared just now, HFSACs and all those ways in assessing and analyzing this data? Because like Dr. Shamila, right, it doesn't stop at reporting. Data must be analyzed in order for us to provide, identify the root cause and provide solution.
In that sense, we are all kind of still learning. So I think I provided some resources just now. If you go to the HFACS website, they actually have quite an extensive resource on their website as to how to begin with this. There are also many resources for RCAs as well, how to conduct fishbone diagrams, how to conduct the YYY questions. So all these are actually pretty available online. But actually, I wanted to highlight that more than just the designing of the form and collecting the form, as with any new system, there is always a need to create buy-in. So if you want to create a new system and tell people, oh, okay, now you have to report all your medication errors, you kind of also need to advertise and tell them why it is important. You can conduct audits as to how many medication errors have occurred. You can also, present, I think, Dr. Shamaila's presentation, I think, bring across the cost involved in medication errors, patient morbidity, cost to the dollar cost to the hospital. So all these are important to present to the department before you even embark on forming a committee, for example.
Yeah, thank you very much, Suchi. And then I think with that, we would like to thank everyone, and we would like to, of course, on behalf of our team, I am grateful for your time, attention, and participation. And we hope that with this session, we managed to help you better understand the crucial differences between medication errors and near misses, and why both are essential to report and learn from. Remember, every near miss you recognize and report is an opportunity to improve patient safety and strengthen our healthcare system. And let's continue to build a culture where we value openness, learning, and continuous improvement over blame. Together, we can move closer to our goal of zero harm. So, but before we formally close, I will just remind everyone that yes, we will provide a certificate of attendance after you have completed the post-webinar survey. And of course, it will be emailed tomorrow in the afternoon. It's not February, it's May 19 tomorrow. So yes, please key in your full name and email. Yeah, so that will be sent to you directly. This session is being recorded and it will be uploaded later in our YouTube and Facebook channel. And I would like to highlight that ASPA is a nonprofit organization. And of course, ASPA's mission is to foster the highest standard of pediatric anesthesia in Asia. Hence, we seek your help and to donate and help us in our cause. So please scan the QR code and donate. Our next webinar will be on the 20th of July. It will be a pediatric sedation webinar. So please stay tuned and for the announcement of the exact details for the webinar. So with that, again, we would like to thank everyone for your commitment, for all of your commitment to patient safety. Until next session, stay safe, stay proactive, and let's keep learning together. Thank you very much, everyone.
Thank you.
Thank you.